Next up is the plenary symposium on hepatobiliary surgery, and this will be chaired by Professor Aloka Pathirana, who is a professor of surgery in the University of Sriwardhana, and Professor Rohan Siriwardhana, who is a professor of surgery at the University of Kelaniya. Over to you, sir.
Good afternoon, ladies and gentlemen. Welcome to the 8th Symposium of the Sri Lanka Surgical Congress 2020. And it's on Hepato-pancreatico-biliary surgery. And we have three eminent speakers today. And the first would be Dr. Arinda Dharmapala, who is a senior lecturer in surgery at the University of Pathirana. He's also an honorary consultant surgeon at the Teaching Hospital of Pathirana. And he has special interest in hepatobiliary surgery and pancreatic surgery. And currently the head of surgery at the Faculty of Medicine at the University of Pathirana. Over to you, Arinda.
Good afternoon, ladies and gentlemen. Firstly, I would like to thank the President and the Council of College of Surgeons of Sri Lanka for giving me this opportunity to deliver a talk and share some knowledge with you all. This is a HPB symposium, and I have given the task of delivering the first talk on selecting a patient with liver metastasis for resection. This talk is based on the current evidence, and also it will be a practical lecture for Sri Lankan setting. Now, as you all know, metastasis in the liver is stage 4 disease, and it denotes advanced disease. Right? And if you don't do anything for these patients, their median survival is usually less than 6 months. So there is nothing much that we can offer them, right? If you don't do anything. But now there is hope for these patients, right? There are certain malignancies that have shown very good prognosis and survival after resection. Especially colorectal cancer is being the cornerstone for this approach, and also neuroendocrine tumors and even carcinoids have shown benefit, and also they have shown there is good survival advantage for these patients, right, who are in stage 4. And when we do the liver resection, their 5-year survivals have been shown to be around 50s and 70s. Now, cancers which are established and which are in the guidelines, right? These are colorectal cancers, neuroendocrine tumors, and gastrointestinal stromal tumors. Now, all these tumors show a very good 5-year survival rates ranging from 40 to 70%. And then there are other cancers which can be considered, right? In very selective situations, I would say, who are having very stable disease, and if you can say in metachronous lesions, and on tumors which shows good prognostic factors, and also tumors which are chemosensitive, we can consider for liver resection. And these also have shown relatively good 5-year survivals, right? But these again are not consistent, but have shown some good results. Then there are other group of patients, malignancies, like hepatobiliary and pancreatic malignancies, thyroid malignancies, and esophageal malignancies, where they have shown not recommended because they have shown very poor outcome after liver resections, and also the data that is there regarding liver resections is limited and scarce. So because of that, we usually don't consider these malignancies, even though they are common in Sri Lanka. We don't consider doing liver resections for these malignancies. Now, if you take a hypothetical case, because colorectal malignancy is taken as the cornerstone or the main marker of liver resections for metastatic disease, we can take a hypothetical case where a 58-year-old male patient who has got a right-sided chronic lesion, cancer, found to have a single metastasis, 5 to 6 centimeter lesion in segment 7 of the liver. He is otherwise fit and well. He has no comorbidities or allergies. Right, let's take this patient. Now, do we have to consider doing a histological diagnosis? It is not necessary. Imaging itself is enough. If the imaging is quite confirmatory of a metastasis, then we don't need to do histological diagnosis. But in minority of the cases, sometimes imaging may be inadequate or maybe doubtful, or you may encounter lesions where you have done the primary surgery a few years ago and then they present with a metachronous lesion. So in those situations, in special circumstances, you might consider doing a biopsy. Because usually, otherwise, biopsy is not indicated. As you all know, biopsy can lead to morbidity, bleeding, and also seedlings. Now, next important thing that we have to rule out before we embark on liver resection is exclusion of secondaries elsewhere. For this, a contrast NSCT, thorax, abdomen, and pelvis is adequate. Guidelines too is recommending this. But once you make a diagnosis of a metastatic disease in the liver by the CT scan, we might consider doing MRI scan, which is with contrast, which is not really essential, but it is recommended by the guidelines so that your diagnosis of liver metastasis is quite certain, right? Because we simply depend on the imaging. Because of this fact, we consider doing MRI scans once we see the liver met. Now, when you exclude the extrahepatic disease, do we have to go further and do a PET scan to exclude extrahepatic disease? Currently, it is not recommended. But again, it may be useful in certain situations where, for an example, you happen to see a non-characterizing nodule in the peritoneum. You don't know whether it's a secondary or just a benign nodule. Or else you're planning on a major liver resection, like extended liver resections, and then you have some multiple liver mets, and you're trying for an extended major resection. In those situations, you just want to make sure that your surgery is going to be worthwhile. You can do a PET scan to rule out an extrahepatic disease. Otherwise, guidelines doesn't say you need to do PET scans for routine cases. Now, is the extrahepatic disease a contraindication for liver resections? No, it is a very careful no. You can go ahead with multivisceral resections. It has shown improved survival and disease-free survival in these patients with multivisceral resections. And if you are envisaging on something like this, a multivisceral resection, I would say this is the ideal time to get a PET scan. But multivisceral resections in carefully selected patients can offer them even a cure. We do resect pulmonary metastases, lymph node masses, or single peritoneal nodules, which have been stable for some time, can be considered for liver resections, and also the extrahepatic disease. Now, when you talk about resectability, once you have done the above, selecting the correct tumor, exclusion or inclusion of extrahepatic disease, next thing that one has to determine is that whether you will be able to leave behind liver volume which is enough for the patient's survival. The part of the liver that you will leave behind is known as future remnant liver. Right? When we are considering this, we don't only consider the volume or the quantity, but also the quality of the liver. In a normal liver, we can take about 2/3 of the liver out. In a diseased liver, I would say fatty or a cirrhotic liver, we have to leave about 2/3 of the liver in the patient. Otherwise, it's going to be inadequate. Now, conventionally, we had very strict guidelines. We had, they wanted a 1 centimeter margin, and we are restricting our liver resections to the tumors which are, less than 5 centimeters, and only unilobar metastases were resected. So there are a lot of restrictions. But now, conventionally, now contemporary, we are just worried about, having just inflow of arterial supply and portal venous supply with outflow with one hepatic vein and biliary drainage, minimum of 2 contiguous segments with a 1 millimeter resection margin. Now, this is one of the tumors that we have resected, extended right hepatectomy, leaving behind just 2 and 3 segments for a metastatic disease. We can do this, and this has shown good results. Now, R0 resections, R0 has become 1 millimeter from 1 centimeter because it has shown that there were no additional benefit having extra tissues more than 1 millimeter. And also, when analyzing the recurrences in the liver, it has shown that majority or most of the recurrences occur not in the resection margin but somewhere else in the liver, right? And R0 resections, 1 millimeter is enough, and it has also shown that re-resection for R1 to make it R0 has not shown any additional benefit. Now, why the resection is best mode to treat liver metastasis? Because overall 5-year survival rate is about 38 to 70%, and 10-year survival is 26. So this is the best way, if you can resect the metastasis, best way to treat, and with a mortality of 1 to 5%. Now, once we decided to do the resection, sometimes we might encounter situations where you cannot really do resection. Maybe due to the tumor involvement is slightly bigger than what you expect, and or tumor may be very close to vital structures, close to the hilum, where it cannot be compromised. You might have a situation where you feel that the volume that you will leave behind is inadequate. In these situations, whether there are any things that we can do to bail out in this situation, right? Yes, we can overcome this marginal situation. We can shrink the tumor by giving conversion chemotherapy, or else we can do parenchymal enhancement, right, by various procedures like portal vein embolization or associated liver partition with portal vein embolization with stage hepatectomy. It's called ALPS. These procedures can be done to improve the resectability. Now, conversion chemotherapy has shown to increase the resection rate by about 15 to 30% of the patients who are having this marginal disease. And then we can achieve about 87% R0 resections in those resected specimens. And borderline resectable disease due to insufficient parenchyma, we can do portal vein embolization, where my next speaker is going to talk about, and also ALPS procedures, associated liver partition with portal vein embolization and stage hepatectomy, are the two procedures where we can enhance the future remnant liver, right, and enabling us to resect the metastasis, right? Now, if the resection is amenable, let's say we can do the resection, what is the best way to resect this? Do we do a metatasectomy, right, non-anatomical metatasectomies, or anatomical resections? Now, anatomical resection seems to be a more oncological. There's a more oncological basis in there, where you are taking the inflow, outflow, and a segment, right? And that is more oncologically accepted. But it has shown that metatasectomy is equally efficient and equally good and safe, and we can stick to metatasectomies, non-anatomical metatasectomies, if we have to resect. So, so now non-anatomical metatasectomy seems to be the preferred choice. We want to preserve more and more parenchyma because it has shown that, that metachronous lesions that may appear years later too can be resected with liver resections with equally good prognosis. Therefore, I would say look at it like in a situation where Crohn's disease, where you do ileal resections, limited ileal resections, like that we have to think of the metastatic disease of the liver also in similar fashion and do parenchyma preserving resections. Right. Now, even laparoscopic surgical resections have shown equally good results, right? Equally good results for metatasectomies, but it is still not proven on major resection of livers. So, but for minor resections, you can go ahead and do a laparoscopic resection. Re-resection and stage resections are also considered to be equally effective, and we can go ahead and do re-resections and plan out stage resections for colorectal metastasis. Now, what is the optimal sequencing? When shall we do the primary or when shall we do the secondary? There are no strict guidelines. It all depends on the clinical situation. Like, let's say that we do a primary surgery for a symptomatic colon cancer, right? Then, of course, we have to do primary first. Or else we have a situation where the liver metastasis is marginally resectable liver metastasis. Whilst awaiting or before conversion chemotherapy, we can do the primary. Right? Then secondary first, usually asymptomatic primary patients, like who are with rectal cancers or asymptomatic patients, we can do the secondary first, right? And more pendulum is towards that side to do the secondary first if there's asymptomatic colon cancer, because we consider liver as the limiting factor for resection. So you do the metastasectomy first and then do the primary. Or now more and more emphasis is given on simultaneous resections because it saves hospital time and it has shown equally good results. But only thing that you must remember is that one of the procedures has to be a minor surgery. Either you do a right hemicolectomy with a metastasectomy, or if you are doing a left colectomies, then it should be single wedge resections of the liver, but you don't do anatomical resections, big liver resections with a major colorectal cancer. So it is how you see it, but it is recommended and it is more and more acceptable now to do both the procedures together. Right. That concludes my talk, and thank you very much for listening. These are my references.
Thank you, Arinda. Our next speaker is Dr. Menon. He is one of the top liver surgeons from UK. He's a consultant hepatobiliary and transplant surgeon from King's College Hospital, London. He's clinical lead of liver transplant, HPV surgery, and training in HPV surgery. Over to Krish.
Professor Jayendra Fernando, President of the Royal College of Surgeons of Sri Lanka, Chairpersons Aloka, Pathirana, and Rohan Siriwardhana, who I know very well. Ladies and gentlemen, good afternoon. It's a real pleasure to be invited to speak at the Sri Lankan Surgical Congress. When we talk about liver volume augmentation, what we're indeed referring to, sorry, my screen's gone.
We can see you.
Slide's not moving, sorry. I'm sharing my screen. You not got the...
Still not.
We can't see the share screen.
Okay, now it's coming. Okay. Yeah, now it's working. Yeah. Are you able to see it now?
No.
Next slide coming up there. No.
No, not yet.
Okay. Okay. Can you see it now?
We can see it now. We can see it now.
Sorry about this. When we talk about liver volume augmentation, what we're indeed referring to is inducing liver regeneration. What I'm going to do today is I'm going to talk through some of the indications, why we perform extended resections, what are the indications we do it for. I'm going to talk through the factors that influence our decision-making process in liver volume augmentation. I'm going to then talk through the techniques of liver volume augmentation and share with you some of my technical videos on how we can demonstrate the use of these techniques, and hopefully conclude, by saying what are the pointers in which way we should go. So liver volume augmentation. Now, most common indications that we perform extended hepatectomies are, as we heard from the previous speaker, for colorectal liver metastases, neuroendocrine tumors, and other liver metastases. The other common indication is primary liver tumors, particularly hepatocellular carcinoma. However, when we talk about liver volume augmentation, often our focus is on the remnant liver volume, which is the physical amount of liver that you're going to leave behind. However, what is more important is the functional liver volume. In other words, what you're leaving behind, how functionally good it is. And the only way of sometimes assessing this is by using dye tests with indocyanine green. What is the ideal liver volume? In a fit, healthy individual, 25 to 30%, particularly if you have a normal liver, is considered sufficient. What we do know is that quality of background liver does influence the safe limits of the remnant liver volume. When you get chemotherapy-associated liver injury, particularly when you give chemotherapy for colorectal liver metastases, or if you have a steatotic liver, particularly in modern-day liver surgery, where we're dealing with obese patients with NAFLD, or if they have a fibrotic liver in the background of, when you got hepatocellular carcinoma with chronic liver disease or viral hepatitis, in all of these groups of patients, the remnant liver volume that is required is increased from what is 25 to 30% to usually 35 to 40%, more like 40%. And this is important to remember before embarking on a liver resection. This is an example of a patient, and as you can see here in picture A, you can see a large colorectal liver metastases in the right lobe of the liver. The background liver appears normal. Then you give this patient toxic chemotherapy, and what happens is you get a good response to the tumor, which shrinks in size, but the liver attenuation changes and goes black. In other words, you get fat deposition and chemotherapy-associated liver injury. Slide C shows you the histological normal liver, and D shows you the fat droplets within the liver that has sustained chemotherapy-associated liver injury. Therefore, hepatic toxicity from chemotherapy causes a degree of steatosis and fibrosis. There is a reduction in hepatic attenuation on CT. What we do not know is a natural history and the effect on hepatic function. However, doing a preoperative stress test with portal vein embolization is sometimes good to assess regeneration before you proceed to doing an extended hepatectomy. Fibrotic livers, particularly when you're dealing with hepatocellular carcinoma, in fibrosis, we do know that the liver regeneration is slow and sometimes unsatisfactory. A fibroscan can be helpful sometimes to categorize the degree of fibrosis, but again, can be inaccurate at times. And therefore, you end up sometimes doing a biopsy of the non-tumoral liver to actually understand the degree of liver damage. And this is important before embarking on a major extended hepatectomy. Then come the oncological factors. Tackling the disease in the remnant liver at the first stage is very important because that's how you get oncological success. There is a clear risk of tumor progression between the two stages, and that can then therefore render the patient unresectable. What one should therefore consider is chemotherapy after the first stage of portal vein embolization so that you can keep the tumor progression under check and therefore allow you to proceed to doing the second stage safely. What are the techniques of liver volume augmentation? One can either do a portal vein embolization or a portal vein ligation, and you can do this radiologically or laparoscopically. And as a minimal access HPB surgeon and transplant surgeon, I prefer to perform the portal vein ligation laparoscopically because it allows you to get the patients out of hospital quickly and avoids the waiting times for the radiological procedure. When portal vein embolization sometimes is not successful in actually augmenting the liver volume, you may have to combine this with hepatic vein embolization, and this is done radiologically. We heard from the previous speaker about the ALPS procedure, and this can be performed either open or laparoscopic. Partial ALPS is a newer concept that's come about where you transect only 50% of the parenchyma that reduces morbidity. And again, this can be performed either open or by the laparoscopic approach. Portal vein embolization can be done, as we know, surgically or radiologically, but there is a 4 to 6 week wait before you can get regeneration of the liver. There is also a need to repeat the imaging to confirm volume augmentation before proceeding to resection. And therefore, as I mentioned earlier, it's important to consider chemotherapy during the 4 to 6 week period before embarking on the resection, again, to avoid unresectability. And patients must be made aware that there is a clear risk of tumor progression while waiting for the second stage of the procedure. This is an example of a young girl with a tumor in the right lobe of the liver. And as you can see, she's large. She's got a BMI of over 40. and the liver volume, which is remnant liver volume, is less than what we would require because it's a fatty liver, and I will show it to you in the pictures later. So we decided to proceed to doing a right portal vein embolization. And as you can see there, right portal vein embolization has been performed, and this will show you that the right liver is now atrophied, and the segments 2, 3, and 4 have hypertrophied as you'd want to. This is seen again in the coronal, and you can see the atrophied right liver there and the whole hypertrophy of the segments 2, 3, and 4. This is a video, and I want to show you first two things here. One is the degree of fat that you see in the remnant liver. And what is interesting is after portal vein embolization, how the right liver, which is your liver they're going to take out, has shrunken and disappeared into the right upper quadrant with the gallbladder buried in there. This is going to make the laparoscopic resection, which is going to be a laparoscopic modified right hepatectomy, a very technically challenging procedure. And it's important as a surgeon to recognize these things and this anatomical distortion that this procedure causes. And therefore, when you start to mobilize these livers, and for the sake of time, I can't go through the whole video, but you can see here, when you start to lift this liver and mobilize it, this is very high risk because it can tear, because the liver is very fatty and fragile. So what is done is mobilization is done very carefully, and I use an energy device called the Lotus, which allows you to safely mobilize this liver. As you can see, I'm using a swab to retract and lift the liver, being very careful, and I use a special retractor called the Pretzel Flex. I operate all in 3-dimension Olympus 3D system. You're seeing this in 2-dimension, so obviously the clarity may be slightly different. I'm still hoping that it's pretty good. I'm going to move on, and you can see here, that's the hypertrophied liver, and you can see it's so yellow and fatty, and the demarcation's been done after ligation of the right artery and portal vein. And then you mark out the area that you're going to resect, the transection line, and then you proceed to doing the transection. And you can see here, I use just a stapler for the hepatic veins. All of the transection is performed using the energy device, which is the Lotus. The hepatectomy, once is complete, you can see that, the whole of the parenchymal transection, there isn't any other device that's been used, such as staplers. So that's the modified extended right hepatectomy for this patient who had a PVE for liver volume augmentation. And that's the last bit of the liver that's being divided, as you can see there, and that's the hepatectomy complete. So moving on to the ALPS and the partial ALPS, this was popularized in Germany. And you can see here, the first step in the ALPS procedure is that you divide the portal vein, you clear the liver tumors from the remnant liver, and then you transect the parenchyma along the intended line of transection. Wait for 2 weeks, do the CT scan and volumetry, and the second step is that the deportalized liver is then removed, rendering the patient tumor-free. You can see the portal vein ligation that's been done here, and the tumor has been removed. Then the liver with the tumors is placed in a bag, and then you proceed to removing the whole of the liver in the second stage of the operation. This is how it looks when you do it as the open technique, as you can see here, and that's where the division is complete. We then transition from the open to the laparoscopic ALPS, knowing fully well that the laparoscopic procedure will carry a shorter length of the stay for the first stage and obviously minimizes morbidity in these patients. So the procedure was first described by Marcel Machado and his group from South America, and then popularized in the rest of the world. The concept of partial ALPS came much later and was again brought about by Lineker, Klavian, and Petrovsky and his group. And what they showed was 50% of the transection of the parenchyma is sufficient to get the hypertrophy and causes the same degree of liver volume augmentation with reduced morbidity and mortality, which is very important. The case that I'm going to present to you is a 55-year-old male with a large 14-centimeter HCC in the right lobe of the liver, extending into segment 4B, with background liver showing portal fibrosis and steatosis. And the FLR was insufficient, and we proceeded to doing a surgical resection, and I decided to do a laparoscopic partial ALPS. And you can see here, this is a large tumor extending into segment 4B, and the remnant liver is insufficient because on biopsy, there was a degree of fibrosis and steatosis. So this is the first stage of the partial ALPS. As you can see, this is a 140-kilo patient, and the ports that are placed are as shown. Right hepatic artery is slung on a tape and lifted up. Technically challenging because I can't take the gallbladder out here because the tumor sits behind the gallbladder. I place a sling because this allows you to retract the hepatic artery and visualize the portal vein much more easily. And this is the first stage, as I said. So the first step would be to try in this patient, provide the...
Excuse me, Krish, you have 1 minute more.
And you can see here the portal vein has been ligated and divided. And the next step is going to be division of the portal vein. And once this is done, then you can see that you can proceed to doing the transaction of the liver. I'm going to move the video forward, and you can see here, this is the plastic bag that's now going to be placed there, which is in the area of the separation. And once this is placed, then you can actually leave that in there to avoid the liver surfaces sticking to each other. And what I'm going to do is, sorry, going back is, sorry about this. I'm going to just take you straight to the second stage. Okay, it doesn't look like it's going to be, yeah. So there you can go. Now it's the second stage that's happening here. And you can see here, I've gone in there and the plastic bag is now going to be removed after it's been, and you can see the liver volume is hypertrophied, and you can now proceed to doing the second stage safely. So in the interest of time, as I can see there, that's the hepatic artery being divided now, and we proceed to the parenchymal transaction in the second stage. So if you were to summarize, if you've got bilobar disease and you need to clear the volume, I would prefer the Alps because this is a procedure of choice. If you've got bilobar disease, the other option to consider is a partial Alps because the mobility is much lesser and you're only transecting 50% of the parenchyma. If you've got unilobar disease, and if you've got particularly background liver disease such as Cali or fibrotic liver, then portal vein embolization should be considered. And if you can't achieve it by portal vein embolization alone, then you should consider PVE plus hepatic vein embolization. And you must consider sandwich chemotherapy during the waiting time for augmentation to avoid disease progression. So in conclusion, liver volume augmentation is necessary to perform a safe hepatectomy if the functional liver remnant is small, and the quality of the liver remnant should be evaluated very carefully before the calculation of the remnant liver volume. And if possible, you should do a functional assessment using ICG. Thank you and stay safe.
Thank you very much, Krish, for that very informative and clear lecture. And may I now introduce Dr. Niroshan Atulugama, who is a consultant oncosurgeon at General Hospital Badulla in Sri Lanka, who has special interest in hepatobiliary, pancreatic surgery, and liver transplant. Over to you, Niroshan.
Yeah, thank you, sir. Thank you very much for your introduction. So I'm going to talk about treatment options other than resection for colorectal liver mets. I'm going to base my talk on colorectal liver mets. So we know that 50 to 60% of colorectal cancer patients will develop liver mets at some point of their disease. And we know that resection provides the best overall survival. However, unfortunately, we know that 80 to 90% of them will present as an unresectable disease at the presentation. So palliative chemo will only provide dismal prognosis with a median survival of 6 to 7 months. So we need a better alternative in between resection and palliative chemotherapy, or maybe a better replacement for resection, because it comes at a price. Even in world-based centers, there is a significant morbidity and mortality. So people have tried all sorts of craziness. There are myriad of options. So we can basically categorize them into 3 broad categories. So one is ablation, the arterial directed therapies, or radiotherapy. So clinical application, all these alternative methods have been practiced first in the palliative setup, or maybe they have been tried in the non-surgical candidates, or as a secondary treatment option when there is a treatment failure, like in a local recurrence where the patient is not fit for a second resection, or when there is inadequate functional liver remnant, or at times as a primary treatment modality, as a sole treatment, or as a hybrid option. So let's talk about all these alternatives and their evidence of use. So RFA in the palliative setup was really confirmed with this CLOCK trial. This is a randomized control trial where unresectable liver metastasis patients are randomized into palliative chemo group versus RFA plus chemo group. And here they showed that there was a significant overall survival benefit and a progression-free survival benefit for RFA group. What about RFA as an upfront treatment option against resection? So this is a 2017 systematic review. Looking at the studies, basically almost all the studies did favor going for an upfront resection. What about RFA as a hybrid option along with partial resection? Again, most of the studies did favor going for a hepatic resection as an upfront option. Again, as I said, it comes at a price, the 30-day mortality is significantly higher for hepatic resection group. So with more accumulation of data, this is the most recent review in 2019. It included 18 randomized studies. However, in comparison to 2017, about nearly only 50% of the studies did show that the hepatic resection had a better overall survival than local recurrence rates. So basically, in other words, 50% of the studies were non-inferior or had equal efficacies. However, in a sub-cohort analysis, they were looking at solitary colorectal liver mets less than 3 centimeters, where the RFA is quite effective. However, still hepatic resection showed significant overall survival and better local recurrence rates. But if you dwell into this analysis, you can see that there were about 7 studies which were looking at solitary colorectal liver mets, and only 2 studies did show that there is a significant 5-year survival. And I want you all to concentrate on this study where you can see that the RFA group did have a significant higher local recurrence rates, but it didn't matter when it comes to 5-year survival. So I think this could be the matter. We are talking about good prognostic disease, single liver metastasis, so it will not matter whether you do a resection or an ablation. But we don't have completed randomized control trials, collision and Aloka 2 RCTs that are underway, and we'll give some conclusions in the future. What about RFA percutaneous versus open? Well, so far all the studies would favor going for an open RFA. Microwave ablation, we know it uses more frictional heating than conductive heat. And again, there are no randomized control trials. These are all retrospective studies with different outcomes. But of course, again, in palliative setup, in our unresectable liver mets, again, systemic chemotherapy tests shown increased longevity. As a curative option, head-to-head comparison with resection, again, it has shown comparable results, but all of these are non-randomized studies. What about RFA versus microwave ablation? We tend to think microwave ablation would do better, but in this cohort analysis, microwave ablation didn't have a better added advantage. And again, microwave ablation comes with a price. There are more biliary complications than RFA. Cryoablation, this is a small RCT comparing head-to-head with cryotherapy versus hepatic resection. Again, in this study, they show there's an additional survival benefit for cryotherapy group. Again, the palliative setup, it has been shown that they have very promising results with cryotherapy. But however, again, the downside is the significant complication profile, cryoshock, bleeding, biliary fistulas are main concerns. Irreversible electroporation, this is the new kid on the block. This is a non-thermal ablative tool. It uses high energy DC, causing nano-sized membrane pores and causing permanent cell death. However, the advantage here is the extracellular matrix remains intact so that it can be used closer to critical structures. And the ColdFire 1 study is a pilot study where they subjected IRE for all the colorectal liver mets, and then subsequently they were resected at the same time. And on histological analysis, it showed that all of these lesions have completely been ablated, and now they have gone to the phase 2 trial. So IRE is mainly about the location. You can use it near all critical structures. So which modality? Well, we don't have randomized control trials, but of course, with the available data, they all show comparable results, so none is superior to the other. So let's look at arterial directed therapies. We know that they used a kind of a toxic metabolite along with ischemia, and we know the experience of TACE in hepatocellular carcinomas. They have been used in patients with unresectable liver disease and have shown a significant overall survival benefit against palliative chemotherapy. But the downside is most of the patients have shown a post-embolization syndrome. Drug-eluting beads, again, they use microspheres loaded with cytotoxic agents. Again, its efficacy has been proven in the palliative setup in unresectable liver disease patients against systemic chemotherapy. And the favorable thing is they have less side effects compared to conventional TACE. SIRT, selective internal radiotherapy, they use, instead of chemotherapy, they use radiolabeled microspheres containing yttrium-90. And here, there is an 3 RCTs pulled together. Unfortunately, did not show any survival benefit or increased hepatic resection rates. But however, the novel trend of yttrium 90 is now it's been considered as an ablative tool, where people are thinking of doing radiation segmentectomies or radiation lobectomies. And of course, again, experience comes from the hepatocellular carcinomas. They have shown there is comparatively contralateral lobe hypertrophy. You can see the functional liver remnant has gone up to 45%, which is comparative to portal vein embolization, although it takes a little bit longer. Hepatic artery infusions, you use continuous infusions through the hepatic artery directly with the high concentrated chemotherapy. Again, in the palliative setup, in non-resectable liver disease patients, they have shown a proven benefit than systemic chemotherapy. What about converting to resectable disease? Again, there are very positive remarks, very positive studies showing that their effectiveness in this setup. Again, the downside is a significant complication profile, hepatic artery dissection, thrombosis, catheter occlusion, and also at the same time, you need a certain amount of expertise to implement this. Radiotherapy, the main issue with radiotherapy is radiation-induced liver disease. However, with stereotactic body radiation, we can give focus, high doses of radiation directly into the liver with tissue sparing. And so this is a study, again, done in unresectable liver-limited disease patients, and they have shown there's a significant benefit compared to systemic chemotherapy. Well, the craziness did not stop there. People have gone into considering doing liver transplants for unresectable liver-limited disease patients. And of course, this is a pilot study including 21 patients where they showed overall survival of 60% at 5 years, which is comparable to all other indications of transplants. However, the downside is, only 35% of patients remain recurrence-free at 1 year. However, they didn't stop there. The main criticism of this is that, you use scarce organs on bad prognostic patients. So as an alternative, they developed this rapid concept where you implant the lateral segment with inflow modulation. And then once there is adequate hypertrophy, they take out the disease segment. So ladies and gentlemen, so in conclusion, I think still we could say the gold standard is for hepatic resection. Alternative options can be used as a palliative option or as a secondary option. As a primary modality, I think still it needs to earn its place, but I think we can be very optimistic. It's just that we need to identify the proper cohorts. And selection among alternatives, I think we have to look for the availability, expertise, and the complication profile. Thank you very much.
Thank you, Niroshan, for that brief but very concise lecture. Because of the time, we have just one question. We'll limit the session for just one question. The question, I think, Krish, I think probably it's directed to you. What is in the second stage of ALPS? How can you prevent the additions? Are there any measures that you take to prevent addition in the second stage?
So the first thing I do is I would prefer that you do it by minimal access approach, because as we know from all other studies, colorectal, upper GI, the adhesions are much lesser if you do the laparoscopic approach. So I think that's one thing. The second thing is when you do the parenchymal transection, because of the time constraints, I didn't show that when you put the plastic sheet to separate the two bits of liver, you can use a sealant called co-seal, which again prevents adhesions. So you just spray it across the surface and it avoids adhesions. But you saw when I went in there the second time, there's very little in there. The plastic sheet just comes out very easily. I would just say minimal access approach is probably the only way to prevent the adhesions. There's no other way that you can prevent adhesions. And there are some people who are adhesion formers and others who are not adhesion formers. And we all know that as surgeons. You find some patients, despite minimal access, you'll go in there, it'll be like a battlefield in there. But sometimes some people don't. But minimal access is the only answer I can give, which reduces adhesions. And perhaps, spraying the co-seal, which is a sealant that prevents adhesions.
Thanks, Krish.
Thank you, Krish. On behalf of the College of Surgeons, I wish to thank all the speakers for spending their time with us today. and for presenting some excellent work. Thank you.
Thank you for the invitation.